Let me tell you something about stroke. It all starts very easy with the monocular blindness. You see here the small emboli in the retinal vessels. They cause the vision loss. It's a retinal ischemia, and it may be a symptomatic high-grade carotid stenosis that causes it. So amaurosis fugax is a risk factor for developing stroke. But hemispheric TIAs have a higher risk. Hemispheric TIAs are half-sided hemiparesis or hemisensory deficits. And the stroke risk after a hemispheric TIA is 10% within the first 2 days. So that's a really high risk within the first 2 days. Let's go to another scenario. Patient comes and he has a Horner syndrome on the right and neck or face pain on the same side. So you think that could be a carotid dissection. The central sympathetic tract, the brainstem, and here on level thoracal 1 or 2, he leaves spinal cord, travels to the ganglion cervicalis superior, then travels around the carotid internal artery and comes to the pupillary. So if you have a dissection in the internal carotid artery, you may have a Horner syndrome. But if you're not sure, you should turn off the light, and then the Horner becomes more pronounced, because now the healthy side, the healthy pupil dilates, and you see the differences much more pronounced than in a bright room. And it really matters, because it's very common in young people, and it starts with local pain first, typical with the Horner syndrome, and stroke follows much later within the next 7 to 10 days. Stroke has a very high mortality, and it's one of the most expensive disorders in industry countries. So this is the typical pattern I want to show you. Head deviation to the right and hemiparesis on the left side. The head deviation to the right comes because the frontal eye field is affected. The hemiparesis on the left comes because the hand and the face is very big represented on the motor cortex in the medial artery territory. Sometimes you see patients that only have a weakness of the hand or of the arm, because embolic strokes are very likely to be located in the watershed area between the anterior and the medial cerebral artery. And exactly here, in this watershed area between these two vascular territories, the hand areal is located, which is a really big area. So if you have a weakness of the hand, of the arm only, think on embolic stroke. And time matters in stroke. There's the golden hour. You don't have much time in stroke, because the number needed to treat with thrombolysis therapy is clearly depending on the time. You need to treat 3 patients in 90 minutes to prevent 1 stroke, but you need to treat 14 patients within 3 to 4.5 hours to treat 1 stroke. So it's really the first hour that helps you. If a patient becomes comatose during transport to the hospital, who initially had the typical stroke pattern with look to the right, hemiparesis left, suggestive of medial cerebral artery stroke, if this patient becomes comatose, he most likely has a bleeding. So these patients then have a bleeding with pressure on the brainstem, which is causing a dilation of the pupil, because now you have an oculomotor paresis, and patients then become abnormal breathing pattern. They do have extensor posturing and need analgosedation and intubation. So that's all I wanted to tell you. We started with amaurosis fugax, a very simple clinical sign that has a risk of stroke, speaking about hemispheric TIAs, then the typical pattern of medial cerebral artery infarction, and then we said that stroke that becomes comatose during transport most likely is a bleeding.